This video lecture, we're going to be talking about play as intervention. So there are several things I want to talk to you about, but for the purposes of time, we're going to keep this lecture to three main points. This is one of those lectures that I've been looking forward to since this is basically my day job. This is what I do. I do play as intervention. There are a lot of really good reasons why we use play as intervention for those of you going into child life or early childhood intervention or clinical work such as therapy, play therapy, art therapy, things like that. There are some really good reasons to intervene using play. I want to talk in this lecture about autism spectrum disorder and how children with autism spectrum disorder differ from typically developing children neurologically, some of the symptoms of ASD, and we'll get into a little bit about the DSM criteria for autism spectrum disorder, how that's diagnosed. The characteristics of infant early childhood mental health issues, how they manifest, and we're going to talk about that. How play-based intervention mitigates developmental delays in infant early childhood mental health issues. That is, again, another big part of what I do in early childhood intervention. And I want to talk a little bit about that because it's not an emerging field globally. This is a global approach to intervention. Infant early childhood mental health is its own field of practice. However, in Texas, because our mental health generally focus is so poor, it's would be considered kind of an emerging field. Even within the work that I do, typically most people don't understand what infant mental health intervention is. And I'm going to apologize. I'm on a girls' trip with a friend, and you're probably going to hear the the air conditioner that's right here next to me in this hotel where I'm at. Okay, so autism spectrum disorder is a neurodevelopmental disorder. There's a couple things I want to say about that. A neurodevelopmental disorder means that it's an issue that starts neurologically. That is a difference neurologically in the way that the brain functions, and it's also developmental, meaning that it didn't start at age 10. It's not like we used to think of schizophrenia, for example, that this wasn't something that children dealt with. This was an early childhood issue, but it was something that sort of appeared as like an adult onset kind of thing, maybe early in adulthood. There are a lot of mental health issues that we are reevaluating that we thought started later, but that actually there were already signs of in early childhood. And autism spectrum disorder has always been understood to have begun early on. There seems to be a genetic link between transmission of ASD. There are what we would call idiopathic origins where it just sort of happens and we don't know why the child has ASD. It is a spectrum disorder, meaning that we used to say like Asperger's or pervasive developmental disorder as ways of describing someone who is a little bit more high functioning who had autism spectrum disorder, but we don't use those terms anymore. Autism spectrum disorder is a spectrum, meaning that there are levels of severity across the disorder. And I want to talk about that. And in our module, I'm giving you a link. I've posted a link to the DSM criteria. It's information from the CDC on the DSM-5 criteria for diagnosis of autism spectrum disorder. This is a big, big topic. I know many of you already work with children with ASD, and so I don't want to make this whole lecture about ASD, but I do want to point out a few things. One is that it affects boys more than girls. You can go, again, online to the CDC website. You can learn a lot about the most recent data on diagnosis, the prevalence within our country of diagnosis. I want to say about this, though, that you have to take those numbers with caution. We've shown this, research has shown this uptick in diagnosis, but you always have to think about something in terms of what's going on within a country, sort of ecologically and just systemically, right? So one thing as an interventionist that I know is when Medicaid started paying 100% for autism spectrum disorder therapies, we now have a lot of uh, programs and therapists and things who have opened up to receive children with ASD and to provide intervention. That's not a bad thing. It just means that we have to approach that with caution, because out in the field, what I'm seeing an awful lot of the time is children being labeled with autism spectrum disorder very early before we know that the diagnosis is stable. Very, very young children, when they go through the testing, you know, their scores can change. And frankly, a lot of the time when a 2-year-old comes in, the psychologist or psychiatrist or developmental pediatrician who are doing the evaluation are asking for parent input. And parents aren't always the most reliable source of information. And so we have to be thoughtful about that. I myself have encountered children who clinics have wanted to hurry and get them in for testing, because even if they don't qualify, you know, they're recommending a lot of different therapies. Even though I'm already providing intervention, it seems like it's become kind of this money-making kind of cash cow thing. And especially my Spanish-speaking families, they are being pushed more towards evaluation and diagnosis at a very early age. And I want to, I'd like to get into that, why we have to be really cautious before we rush to put a label on a child from birth to 5. So the DSM-5 criteria in DSM-5, if you're not familiar, it's the Diagnostic and Statistical Manual for the American Psychological Association. It does provide diagnostic criteria for diagnoses of all kinds of mental health issues. It's used by clinicians to bill for insurance, and it's used for medical coding, right? So you can look at the link and read about the criteria. My caution in that is to remember that this is a global, this affects children's development globally. I know that there has been a pretty large group of people who have been affected by social media and who have also sort of self-diagnosed themselves with ASD. And my caution about that is that ASD does begin in infancy. We have signs of that in infancy. So for someone to say, well, I'm 25 and now I think that my problems are related to ASD, and I'm diagnosing myself with that, it's like a lot of different things. We have to really be careful about that. If a person walked and talked and did all of the social emotional things that they should have done in an appropriate developmental timeline, they probably didn't have ASD. I like to tell my clients too, I said, when they say, oh, well, did you hear so-and-so has declared that they have ASD as an adult? And I say ASD is not an excuse to not be nice, to be unkind. So sometimes I think people will call themselves ASD as a way to get over or to explain the fact that they're blunt or direct or maybe not very kind. And that really does a disservice to our friends and clients, students who have ASD, because, they're not mean people. And many times their directness is just because they are so literal in their thinking. So I want to talk a little bit about the neurology of autism spectrum disorder. Again, there seems to be, from what we've seen with regard to patterns in parents and in siblings multiple children in a family that have ASD, it seems to be that there's some sort of a genetic link. Not always, but it seems to be. There are some differences now because we have good tools like the MRI and fMRI, and we can see the brain in action. We know that children with ASD And individuals generally with ASD seem to have a neurological preference for objects over people. And so, it's common to see children with ASD who prefer to look at screens or prefer to play with things rather than spend time with other people. But depending on um, how significant the severity of the disorder also affects how much they might perseverate on objects rather than people. And no matter how severe someone's diagnosis may be, or their classification of ASD may be, they still do desire connection with other people. It just it may be, it's definitely going to be hampered and impaired by some of these neurological, um, differences and these difficulties that they have with regard to preference for people. So again, severity is the criteria for ASD, and its severity is based on the idea of how significant the symptoms that they have or that they are manifesting affect their day-to-day life. Do they require a significant level of support? Then they might be level 3. Do they require some support? It might be like a lot of support, but maybe not. They can do some things. That might be level 2. And then if they require a minimal amount of support, that would be level 1. I've had students at TWU with ASD, and they are able to function very well. And you probably know people, young adults or grown, older adults who have ASD, and you may notice that they just, have kind of a restricted level of interest. I have an adult friend who has ASD, and he's fascinated with Ford trucks. So, he gives people a hard time if they have like a Chevy truck, for example. He really likes Fords, and if somebody comes up and they have a Ford truck, he's got to open the hood and look at all of it, and it's kind of been amusing, and it's just something we all know about him and the way that he functions in the world. It's just his thing. In early childhood, however, when we're doing the initial intake with a family when they're coming for early childhood intervention, and this would be true of all early childhood intervention programs, and pediatricians to a certain extent are looking at developmental information. How in depth they're looking at it is very, subjective. It's very different across communities and across clinics and things like that. But as far as ECI goes, when we have a family come in with some concerns, maybe they were referred by the pediatrician, or maybe their child care provider has some concerns, what we notice and what we flag for ASD concerns will be things like, social or language delays. If a child is not speaking in 2-word phrases at age 2, we're already going to say, okay, there's a concern. It may not be that we see signs of autism, but that automatically raises the concern to a red flag for autism when we see some of, language delays. And then avoidance of eye contact is, one of the, well, it is a neurological difference in children with ASD. So we know that if a child is avoiding eye contact in birth to 3, we know, oh, that's not a good sign. We need to really examine that. The number one sign, though, in birth to 5 is that the child doesn't respond to their name. It's also the most difficult thing to intervene for. So when we see lack of response to name, avoidance of eye contact, and then those language and social skills delay, we are extremely concerned, and we put that up to a red flag for autism. The other thing, too, is like a lack of pointing, which indicates that the child is not engaging in joint attention. And what joint attention is when I'm looking at something and I'm inviting you to look with me. For example, if we're looking at a book together and I point to, show me the apple, or there's the apple, and the child looks in the direction of the point, we're engaging in joint attention. We do that as adults all the time. You may be looking at a friend across the room at a party or in a class or something, and someone says something and you kind of roll your eyes or give some sort of nonverbal communication that they know exactly what you mean simply by looking or making some kind of a facial expression. That's joint attention. It's that joint engagement that people have that is nonverbal but very much social communication. Autism spectrum disorder is definitely an impairment of social communication. And so sometimes that's hard for people to understand that, okay, well, it's just a communication delay. No, it's greater than that. It's a social communication delay, and it makes it really difficult for people to be in connection with other people because the signals may be off. Someone may be using sarcasm, and because they don't understand sarcasm, it doesn't make sense to them what someone else is saying. Or, one of the classic things is a child is not responding to the look. Parents will give the kind of the mean mug look that's like, "Hey, stop," but they don't understand that. It makes sense because they're not looking at eye contact. There's actually been research on how neurologically children with autism understand what goes on sort of in this region of your face, that we have a lot of muscles here, and those muscles move in unique ways that convey a lot of emotion and a lot of expression. And so children with autism don't seem to recognize a lot of this region here, and so they're not understanding a lot of what's happening there. So when we think about intervention, and that's what I want to get into in a couple of slides, our intervention is attuned specifically to some of those deficits that are occurring in these areas, okay? So what we have to work on is attunement between caregiver and child, because what typically will happen is you have a child who doesn't respond in the way that typically developing children respond. They're not flirty. They're not trying to get their parents' attention. They're not doing the cooing and the oohing and the intense eye contact that typically developing babies do. So they seem to be kind of fine on their own, or they may even cry when someone is trying to get in there and talk with them and play with them. And so these are children who are often left alone or left in front of a television screen or something because they just don't really seem to need a lot of attention. Some of the families that kind of figure out later that their child's infancy was different is they'll have another child, and that child will be doing all of those flirty and interesting things, trying to get that social attention. And the other child, they were like, we never had to hold her. We didn't have to do all of these things. She just could sit by herself and play by herself, and she was just, kind of on her own. And we start to explain, and parents can kind of see that, oh my goodness, okay, that was the autism. We didn't realize that was the difference. So again, intervention really focuses on trying to shape some of those atypical behaviors and to become more typical, not in a sense because we want them to fit in socially, but because some of the behaviors like joint attention and things like that help us in connecting with one another. And so it's a lot of play-based intervention, which I'm going to talk about in a moment, but it again is definitely pointed towards trying to mitigate some of those atypical behaviors. Okay, now infant mental health, again, like I told you, is more of an emerging field in Texas, but it isn't really worldwide. There's a worldwide infant mental health association. When we think about infant mental health, most of the time when I say, I do infant mental health or early childhood mental health, it's infant and early childhood mental health. But when I speak about this to people, oftentimes they're like, what's that? What does that mean? And a lot of pediatricians don't even know what that means. It's at least not here in Texas. So, I'm not in Texas right now, but you know what I mean. In Texas, typically, it's not that way. So, oftentimes, what I'm having to explain is that we can have mental health issues all across the life course. Some things show up later in life. So there are some things that are more environmental. You can have sort of a, social or some kind of an anxiety issue that became specific to a situation. Like, for example, someone can have a wreck in their car and then they all of a sudden have driving anxiety and they get anxious about getting behind the wheel. And that's something that can be remedied and mitigated through therapeutic techniques, right? Or just getting back in the car, depending on the severity of the accident. But for some mental health issues, they seem to have occurred in that infancy period or early childhood period. Some of it may be related to trauma, experiences of trauma. Some of it may be related to experiences of neglect, abuse. Those are things that can lead to traumatic responses neurologically. We talked a little bit about neurological development already in this course, so I don't want to get back in that too much. We've talked about that, but I do want to say that there is a difference between a mental health issue that is starting to pop up in early childhood and a traumatic event that occurs later, how neurologically that affects development. I do frequently in the work that I do see children who are flagged for autism concerns, like a suspicion of autism, and then I go out to work with them, and what I'm finding is not autism at all. Rather, it's severe anxiety in early childhood. And I'm seeing a little bit more of that. That it's kind of one of the after effects of COVID. And for those of you who haven't had children, or maybe don't have the experience of having like nieces and nephews or something, and have talked to someone who's gone through this, but having a baby, yes, it's the most wonderful experience as far as like the love that a person feels, like a mother or father feel for their child. But it also can be a very triggering experience, especially for people who've had trauma. It can be a very anxiety provoking experience, even if you haven't had trauma, simply because with this great love that you experience, all of a sudden there's this great fear for what happens if I lose this baby, what happens if something happens to this baby. I'm terrified that I might screw up, or I'm terrified that something might happen to this child. And it can become a period of tremendous anxiety, depression, and even in some cases psychosis. So what we see, or what I see an awful lot of the time right now, is that people who had what might have been a typical reaction, typical anxiety reaction, who would have worked through it in the midst of COVID, didn't have the opportunity because they were isolated, or didn't have the opportunity to get out more to resolve that anxiety, because their pediatrician and the information that was going out in the world at the time because of the pandemic was, your child could be at risk of death or whatever because of COVID, so you need to keep them out of the public. You need to keep them at home. And so we've seen that affect development in a lot of different ways, but again, it's manifesting itself with anxious parents, anxious caregivers. So oftentimes when I'm looking at a child and trying to kind of assess what's going on, could this be autism? Might it be something else? I'm looking to see, do they tick the boxes of those things that I talked about in the previous slide? Are they making eye contact? Are they capable of making eye contact? Are they avoiding it? Are they capable of kind of, regulating themselves? Can they be around other people? Or are they kind of like irrationally afraid and excessively afraid of a child coming near, or an adult in the room? Because stranger anxiety is typical. Separation anxiety can be typical at certain stages in infancy and early childhood. But when it's irrational, like, an example would be, I worked with a little girl who had severe anxiety, social anxiety, and we would go into like a little gymnastics classroom. And if an infant crawled up to her, and she was already over, 2, like 2.5 at this point, or closer to 30 months. If an infant, well, no, 2.5. If an infant came up, she would absolutely lose her mind, just scream and cry, and just experiencing terror. I had never seen terror like this in a child, as though the little infant was deadly. And so it's those excessive emotional reactions that are indicative of something else that's not necessarily going to be autism. That's severe anxiety. I will say autism has co-occurring disorders like anxiety, like ADHD, like OCD. But this is where we don't have those common signs of ASD. We have the fear, but we don't have the other. Again, not being developmentally appropriate for age. And I'm not talking about like a child sees a bug and they scream. I'm talking about a person, when they see a person and they freak out, or a noise, something happens, and all of a sudden they're in kind of a fight, flight, freeze, faint, that sort of primitive, sort of fearful response, and it's really out of proportion to what the thing was that they heard or saw or whatever. The other thing too is when I see signs of anxiety, depression, or other mental health issues in the caregivers, I'm automatically going to be looking at the child, because there's a big correlation between both, right? And again, it goes back to, if I haven't resolved my anxiety when my child was born, if I'm experiencing depression, if I'm experiencing postpartum psychosis or just psychosis, bipolar disorder, whatever it might be, if I have those issues, A, there's a genetic link, but B, my reactions to things are going to be atypical as well, which is going to affect my own child's reaction. Some of the most interesting conversations I have with caregivers have to do with their own anxiety, and when we start to examine it and name it and identify it for what it is, the work goes so much more smoothly, because they can then identify how they feel in their body when they're feeling anxious or depressed or whatever, and then they can identify those signs in their child. And the nice thing about doing this work is that when I work with families and we're mitigating some of their own mental health issues and they are aware of it, we do a lot of intervention that is joint and like kind of collaborative, because they see the value in helping their child, but then in doing so, they're helping themselves. And one in that particular family that I spoke about, the little girl that had the severe anxiety, her mother had it, her grandmother had it, her aunts had it. And when we gave a name for that feeling, for what that was she was feeling in her body, the mom told me she had gone to her mother and sisters, and she said, here's what is going on in my daughter. She said her mother said to her, I didn't know there was a name for this. I've always had this. I didn't know this is what the name of it was. And they were all able to sort of identify, have conversation about it, and it helped all of them to mitigate their own anxiety. And the mom even said to me, it helps me to help her. I thought that was a really beautiful way of expressing what infant mental health does. Is it's a collaborative effort to mitigate some of those early childhood issues. We see significant improvement in symptoms with intervention where ASD takes far longer. My higher functioning clients do, maybe will be a little bit more rapid in some of the issues that we're trying to mitigate. But typically, it takes a long time to reduce the anxiety that comes with eye contact in children with ASD, or to help, like responding to name is the hardest one to intervene for. It takes a lot of time. It can take years sometimes. It definitely takes months. But if I have a child who has mental health issues, particularly related to anxiety, the intervention that we do, because it's play-based, reduces stress, which is what we're going to talk about in the next slide. But we see significant improvements. I start to see a lot more language. I start to see a lot more enjoyment of activities. They're not quite so clingy. They'll, when we go out to the park or something, I'll see them get several feet away from their mother or father. And you just start to see a big difference in their development simply by the fact that we've started working together. Where, like you said, if it's ASD, I don't see such a rapid improvement in these symptoms. One thing I want to point out about anxiety and its effect on development, one of the reasons that children present to us with a language delay, and if they have anxiety, is because if they're at a heightened state of anxiety, that part of their brain, the amygdala, that signals to us that we're in danger, also takes the language portion, right up here, offline. And so, it's just like if you've ever been in a situation where you were terrified, you couldn't really think straight probably either. It's a very primitive response. So imagine a child who's in high stress all the time, either due to trauma or some chronic issue that's going on, or due to anxiety because the messages they're receiving from their caregivers are things aren't safe, it's not okay. of course we're going to see a delay in language because their language center is not operating at its highest capacity because they are in the midst of anxiety and fear. All right, so this is really very simple. How play helps, one, like I kind of have alluded to this, that it reinforces the bond between caregiver and child. We see this in ASD. Oftentimes, if parents aren't getting the signals from their child that indicate that they want interaction, then they go away from their child. What we do within the play-based intervention that I'm doing with the families that have children with a suspicion of ASD or even a diagnosis of ASD is we're working to reinforce that bond and to encourage them to be present with their child and for their child to be present with them. It's called attunement, that connection between people. It's like the parent is the magnet and the child is the steel that comes to the magnet. I'm trying to work through that. And even when it's not ASD, it's something else. It's just a simple language delay. We aren't sure why it happened, but the child has a language delay or they have some other kind of delay. When we do play-based intervention, what that helps to reinforce is that attention, that bond, that connection and relationship, and it just stimulates that. And of course, we do better in connection. I've said many times that is the focus of the work that I do, is fostering and building connection. My strong belief and passion is that we are all wired for connection, that our brains work best when we're in connection with one another. We regulate one another, and we are better able to regulate ourselves when we have healthy co-regulation with other people. So of course, when children are needing a lot of co-regulation in that early childhood and infancy period, having parents or caregivers play with the child or children helps to reinforce that bond. It helps to help them to just be in connection with one another. So play being an enjoyable activity is something that they're engaging in together. It can bring parents and caregivers back to the place of their own childhood if it was happy, to the things that they like to play with. So, oftentimes I'm asking parents, what were your favorite things to play with, and how can we bring that in to what we're doing in our work together? How can you build on, like if you, oh, I'd forgotten how much I enjoyed painting. Okay, well, let's paint together, things like that. Again, being an enjoyable activity, it reduces stress for both the caregiver and the child. So for my most anxious parents, I will invite them to come in and let's color together. Let's play Play-Doh together. Let's do some creative activity like painting. Whatever that is, we're playing together. One of my favorite things to do is to make sensory bins with families, and we'll make a fun little sensory bin with rice or beans or whatever. And the caregiver is saying, "Oh, I really like this. This is so fun." One of the children I'd see that has been diagnosed with ASD, we did a sensory bin one week with mom and grandma, and they just loved it. They absolutely loved it. And then I brought out, different kinds of painting activities to do with them. And the last time I went out, we were watercolor painting, and the mom just sat and painted while her daughter was engaged in another activity. And she said, I'm going to need to do this. I really like this. I really enjoy this. And she had her own anxiety was diminished. So it does reduce stress when we engage in both play and creative activities. And so we can't really minimize how important that is. It does help clear that stress hormone, cortisol, from our systems when we are engaged in stress-reducing activities. It does produce better results. There's that clinical kind of medical model that is often something that we see in different places where the child or the parent or the child goes to the person who has the expertise, and then they come back to the parent, and then the parent has no idea what has just happened. But in a naturalistic intervention setting like early childhood intervention, it is producing better results because it's embedded in the daily routine. Play takes place all day, every day. It's not something that we are saying in a prescriptive way, like you have to do this activity 5 times today. It's more like, let's think about play globally and how can we engage in play with our children and intervene in such a way that's fun and natural. Because like I said, play is natural. It's the way that children learn. So it does produce better results. The most important thing, especially for children who have ASD, is that it's generalizable. One of the things when I do intervention, I explain to families is that whatever we are learning, we want it to generalize to other settings and other times. So with play, if we're learning how to stack blocks, again, it's not prescriptive. It can become fun, and when a child is engaged in something that's fun, they're going to do it lots of times. So again, if I'm working on fine motor skills and it's hard at first, but I'm getting the hang of it, that's an accomplishment. And the look of joy on a child's face when they're able to stack 4 or 5 blocks when they couldn't do 1 or 2 because they've gotten stronger, or their balance and coordination, their fine motor skills have improved. That is so wonderful to see, because not only did they love what they just did, now they want to do it more because it's fun. So it does produce better results because it's just something that we want to, the children want to engage in, parents want to engage in when they see the value of it. So again, it generalizes across settings and times. And like I said too, it is the natural way that children learn. So, it's important that children are given opportunity to learn naturally rather than in a prescriptive fashion of, here's a flashcard, look at this and do this and do this. And that, while there may be a place for that, that's not necessarily a terrible thing. When it is more naturalistic, it makes more sense because it is something that a child is going to want to engage in. The last thing I wanted to say with regard to this particular lecture and why I wanted you to, talk about, or I wanted to talk with you before you read the chapter is, this is an older book. It is, written from a different, it's really only, when we think about publishing, the book was published in 2010, 2011. We think about that in terms of it's 2023, that's, 12, 13 years ago. But the writing of it probably took 2 or 3 years. So it's already dated somewhat in language. Many of you are familiar with person first language, and that we don't say, mental retardation really anymore. Even though retardation itself is a clinical term, it's not really meant to be a negative term. It has used so much negatively in our culture that it's not really the way we speak about individuals who have some kind of an intellectual disability or delay. So I would say when you read the book, when you look through it, remember that that's not really a term we would use anymore. It's not considered appropriate anymore. The other thing too is when we think about person first language and we talk about people with disabilities or people who have special needs, because special needs does not necessarily mean someone who has a developmental delay. It can mean a person who's gifted, or a person who has trauma, or a person who has, some unique learning or a unique way that they learn. It doesn't necessarily mean a disability, but when we think about someone who has a disability, we should think about it as a disability and say, this person has a learning disability, or this person has a hearing impairment. We're not defining them in the terms of that. We're placing them first in our language so that then the disability or the delay or the difference or the exceptionality does not define them. They are an individual who happens to have this little, this particular characteristic or unique aspect of themselves. They're not defined by how they learn, or not defined by how they walk, or not defined by how they experience the world. So the only thing about that is within the autistic community, within the deaf community, that is a difference. So the deaf community does actually consider themselves to be a culture that is its own thing. And so we would, even though I might refer to the children on my caseload, maybe someone who has a hearing impairment, properly a person belongs to the deaf culture. And they do sort of, do feel sort of bonded through that impairment as part of their own identity. Excuse me. The other thing too is that with autism, depending upon the individual, some people really do prefer to be considered an autistic individual rather than a person with autism. So, it's okay to ask and say, how would you prefer to be, how do you refer to people with autism if you're speaking to someone? Because I will say this, I would never say to someone who has autism, how would you like me to refer to you as an autistic person? Because that doesn't even make sense. That person wants to be referred by their name. We would say, well, that's Jolene, who, that's my friend Jolene. And maybe if someone, we're in conversation, we get to know them, we maybe want to ask a little bit more about their own viewpoints on autism if we know they've been diagnosed. My experience has been that most of the people that I've ever worked with who were adults who had autism spectrum disorder, they have awareness of that, and they like to put that out front. They like to let people know that they have it, so that it can kind of help to explain some of their stems or their tics or whatever, because again, autism does often have so many other co-occurring disorders. So again, just for the dignity of the people that we work with, we want to think about person first language, but we want to also honor the culture that people belong to, and make sure that when we are engaging in conversation, we do that respectfully and with a desire for better understanding. Not necessarily, again, just like we would with someone who belongs to a particular ethnicity, and not engaging in microaggression where we expect that person to speak on behalf of all persons with autism or all persons who are deaf. It would be just getting to know that person and wanting to know their feelings and how they identify, and how what their viewpoint is on life, because it's when you've met one person with autism, you've met one person with autism, you haven't met all of the people with autism. So I hope that this has been informative for you. I was looking forward to doing this lecture because I've really wanted to speak about the work that we do out in the field. If you're interested at all in early childhood intervention or play as an intervention excuse me, strategy, I hope that this has been helpful. We kind of see how play is a way that we use, or play is something that we use as intervention. Okay, with that, I'm going to close. Again, as always, if you have any questions, please be sure and reach out, and I appreciate your attention and your time. Have a great week.